Okay, I guess we'll get started with this lecture. And I'll have to ask some, I guess, pop questions to make sure you're not falling asleep after lunch. All right. So who's excited to learn about this? Yay! Adjusted rate differences and rate ratios. Exciting. And for the Stata users, I have code in Stata. I know you're in a minority here. How many do we have? 4. Just 4 total. But I am a Stata proponent. I do think that a lot of things are easier in Stata, and it costs a lot less. So if you're looking to save some money for your health department and spend that elsewhere, maybe in data improvements or systems capacity, that would be a great way to save some money for you. You get a perpetual license that you don't have to update every year. And if you have a student status, it's really cheap. I have not been paid by Stata, but I do like it. So I'm going to cover the importance of absolute and relative measures, some problems with the odds ratio as a relative measure, and why I think we should never use it. But we are using it in an upcoming exercise, but there's ways that we could back calculate. And I'm going to show you those ways. Estimating adjusted rate differences and rate ratios, and looking at some of those additive and multiplicative interactions. So Deb covered the multiplicative part, and I'm going to cover looking at differences, because sometimes you can have additive interactions without multiplicative and vice versa, but usually multiplicative is a higher standard. So there are different measures of association, as you obviously know, and we've talked about the difference. The subtraction of risk is the attributable risk, and the relative risk or rate ratio is the division of those two. So the advantages of absolute measures are that you can assess actual impact and numbers affected. That's what we covered yesterday, the excess cases, those really powerful numbers that can speak to policymakers and be persuasive. You can also calculate number needed to treat. Has anyone ever done this? Okay. It's really kind of cool. All it is 1 over the rate difference. And so you're just seeing how many rate differences you have to add up to prevent one case of your outcome. And if your risk difference is positive, that's like the number needed to harm. So it's kind of a cool concept, and maybe Sarah will be covering some of it in the economic evaluation. And you really need the absolute measures for decomposition analysis that we covered yesterday. But it can be difficult, these absolute measures, to compare the strength of association across risk factors if there's different baselines, if you're comparing across different outcomes even. So that's the strength kind of the relative measures. They help to control or standardize assessments across indicators by person, place, and time, for example, or to compare the strength or magnitude of the association. They're more often used in etiologic studies, but that's changing more and more. You see a lot of people really doing absolute epidemiology. And someone I've worked with who has produced some of these slides later on, Jay Kaufman at McGill University, he's kind of a big proponent of only using absolute measures. So you can see how these relative measures could be misleading. So a relative risk of 2 sounds really dramatic to people. Your risk doubled. But if you'd have no context for that, looking at the absolute percentages, that could translate to only a 1% difference. So you're still very unlikely to have the outcome, and it's a small absolute difference. But it could also be going from 30 to 60%. That's a huge absolute difference, and you're now more likely to have that outcome. So really the absolute measures set the context for relative measures. And they provide complementary information. When you're just evaluating a single risk factor, there will be qualitative concordance. So a positive risk difference will be connected to a positive relative risk, and the same with a negative. However, they can be showing inconsistent things when you're looking at interactions, two groups, or time periods. So here's an example from Chicago, actually. And they looked at black-white disparities in a variety of indicators across time. And they concluded that disparities for 6 of 15 indicators widened over time. So Jay, my colleague, he was like, what? I do absolute numbers. The disparity actually declined. And on an absolute scale, it did. So if you look at this, the disparity in 1990 was 28.8. This is tuberculosis, I guess. And the disparity in 2005 was 10.3. So it declined in about 2/3 of the absolute disparity, but still the relative risk increased. The decline for whites was greater on a relative scale than the decline for blacks. So you can see that actually in blacks, they declined by 2/3, whereas the white rate declined by 3/4, 75%. So the actual relative ratio over time actually increased. So what would you show of these two measures? What would you prefer?
I think the absolute makes more sense, but I still think it's helpful to have both.
Exactly. Yep. So that's what I try to advocate, that you really need both. And it's not too hard to do. So Healthy People, which is in charge of looking at disparities and setting these goals in disparity elimination, they concluded that a decline in both measures is the best evidence of progress in disparity elimination. But they're using the relative measures as the primary indicator of progress because they do adjust for changes in the level of the reference point between populations and over time. And they have the advantage of being comparable across indicators that have different baselines. So here's an example where, as I mentioned, multiplicative is more of an extreme standard, but there can be additive interactions that carry important public health implications. So here's an example where we're looking at the pill and smoking on stroke. So in those who don't smoke or take the pill, there are 10 cases. And looking at the joint and multiplicative effects here, we're just subtracting. And the joint effect does exhibit an extra 50 cases versus the expected of 10 plus 20 in both groups. that would be the additive effect. So we're getting 30 more cases than we would have expected just by combining those two risk factors. But on a multiplicative scale, you're getting exactly the same. 2 times 3 is 6. So expected equals observed there. So absolute measures quantify the actual risks and numbers affected and are necessary to interpret the meaning of a given relative risk, whereas the relative measures can allow standardized comparisons across time and groups and indicators. So there is some controversy over which is better because of the difference in interactions. You can see an additive without a multiplicative and vice versa. But for main effects, they're absolutely complementary, and they provide important information in both regards, regardless of what kind of model you're using. So problems of the odds ratio. First of all, they're kind of non-intuitive. We don't think in odds, we think in probabilities. So it's kind of difficult to communicate and interpret them correctly. So we're often tempted to say, oh, there's an odds ratio of 1.3. That's a 30% increase in risk, but that's not true. That's a 30% increase in odds. So it's hard for people to kind of wrap their heads around. And they're not equivalent when we have common outcomes. They're very much exaggerated for the odds. It's not a good approximation. And we have common outcomes in MCH, like breastfeeding, obesity, or medical home. Another issue is that they're not collapsible across strata, and you're looking across data to assess confounding, for example. The crude odds ratio is less than the average of the stratum-specific odds ratios. So that can lead to apparent kind of negative confounding when none exists. So your adjusted odds ratio is greater than your crude. It can also lead to you concluding that there's positive confounding, that or not seeing positive confounding that's actually there. So they can sometimes not be the best for even assessing confounding. And I know we've done that in previous lectures. So I think it's really more about a magnitude issue, and we're mostly assessing this positive confounding and seeing like large differences between crude and adjusted. So it should be okay. The difference between the relative risk and the odds ratio. So the relative risk is just the division of the proportions, whereas the odds ratio, you're subtracting the proportion in the denominator. And you can do a little bit of algebra here and find out the odds ratio equals the relative risk times 1 minus the first probability over 1 minus the second probability. And you can solve for this. I kind of geeked out and tried to see how much or what could happen to achieve a doubling of the odds ratio compared to the relative risk. And so that can happen. You can put in 2 there and put in a P1 and solve for P2. And so that's what I did with a small P1 of 0.1, and when you solve, P2 is 0.55, and so that's a relative risk of 5.5, but a doubled odds ratio. So that's an example where there's a very high effect size, even if the prevalence is small. And then as P1 increases, the distance to P2 doesn't have to be as large. So in this case, if you have a 50% prevalence in your reference and a 25 percentage point increase to 0.75. That's a relative risk of 1.5, but an odds ratio of 3. So basically, you just have to have high prevalence in at least one strata for your odds ratio to be greatly exaggerated. So what are some estimation options for these risk differences and risk ratios? So it was the linear probability model, generalized linear models, and the logistic conversions. And I know Deb has already covered binomial and Poisson, but I'm going to show looking at additive interactions with that. So we'll do a simple and complex data example. So here's data from Vitals, where the outcome is preterm birth, and we have just 3 basic covariates, smoking, race, and age. And this is not like a real example. This is just for learning. Kristen is going to go over more thoughtful model building, but this is just for the purposes of showing how to calculate these. So this would apply to cross-sectional, cohort, population level, or simple random sample data. So the linear probability model, it's very easy to fit. You get a single uniform estimate of the adjusted risk difference. It's very popular among economists. I've used it. I showed it to you yesterday in a Oaxaca model. The disadvantages is that it is possible to get impossible estimates, so adding up probabilities that are more than 1 or less than 0. And it doesn't directly estimate the relative risk. You're only going to get the rate difference here. And Jay says biostatisticians will hate you. I guess they don't prefer this model. It's more popular among economists. So we actually have some economists here. Have you guys used the linear probability model? Nope. Okay. So it's really just a linear regression. And Deb said before, because you're forcing a 0-1 when it's assuming a continuous distribution, you're not going to be estimating the variances correctly. So that assumption of constant variance across the distribution is violated because variance is a function of the probability. You all probably remember PQ over N. That's the measure of variance. So it's tied to the probability. So we have to use robust variance estimates here for these models. So how you can do this in SAS easily is just survey reg. It will automatically do robust errors for you if you just have population-based data. And here, if we're focused on the smoking effect, we get an adjusted risk difference of 2.9% of an increase in preterm birth associated with smoking, adjusted for race and age. And in Stata, it's just regress, and you put in robust variance there, and you get the exact same thing. So the generalized linear model, you do get a single uniform estimate. It's really popular for biostatisticians. I know Deb likes it. It can be difficult to get convergence sometimes, and it is still possible to get impossible values. So perhaps the ideal is the next thing I'm going to talk about is the logistic conversion, and you'll see how we can do that then. But we can go over this quickly because Deb already talked about it. You can do binomial or try Poisson if the binomial fails to converge. And you do have to do what's called a modified Poisson to adjust those standard errors. It has the same problem of assuming or violating the assumption of constant variance for a 0-1 variable. So here's a binomial model, and we get about the same risk difference in SAS, GenMod. And for Stata, you can use two procedures, either GLM or BinReg, and we get the same effect estimate. And for the risk ratio, all you have to do is change the link. Before it was identity, now it's log. And you can put in an estimate statement so that you get that exponentiated coefficient to get the relative rate ratio. So that's a 30%, 31% increase in the rate of preterm birth with smoking. And we'll get the same thing from Stata. You just put in the relative risk and the log link. So now let's look at an additive interaction here. So we're going to look at the interaction between smoking and race. So what is the effect of smoking among white women? Can anyone? White is the reference group. Is it hard for you guys to see? Okay. Yeah, so it's just the smoking effect, because smoking is crossed with race, and so the reference is white. So the main effect here of smoking in this model will represent the effect of smoking among white women. Then the additive interaction is saying that there's a 0.8% increased risk of preterm birth for smoking among Black as compared to white women. So to add up the total effect for Black women, it would be the base of smoking, 0.0272, plus the coefficient for the interaction, and that's 0.035. So what would you think would be kind of responsible for an interaction like this? Any ideas of why the effect of smoking would vary by race?
Some kind of comorbidity that is more common in certain races?
Yeah, this is more like thought-provoking because I thought about it, and yeah, that's a possibility. It would need further exploration. I was thinking perhaps maybe cessation rates were lower for different women by race, so they're maybe smoking more or longer. So that would have to be kind of explored, and if that were a factor, we'd try to kind of build that in programmatically. To improve cessation for minority women. So for Stata, this is the code for the interaction, and you can do what's called lincom afterwards and get the same kind of effect among Black women is 0.035 versus the main effect here for smoking 0.0272. And when we test a multiplicative interaction with the log link, there really isn't a significant interaction. It's kind of borderline, and it's actually negative. And this is because the baseline rates vary so much of preterm birth. So that absolute difference means more to a white woman who has a lower rate than to a black woman who already has a higher rate. So that's why you can see kind of variation and kind of discordance between the two additive versus multiplicative interaction. And you would have missed that altogether if you didn't look at that additive component where we are seeing excess risk of preterm birth associated with smoking for black women. And this is kind of the code in Stata. Again, the LINCOM after the code. And then if the binomial fails to converge, you could try starting with a negative intercept. This is kind of a trick to kind of improve convergence. So there's the SAS code for that. You can try starting at a negative number. That sometimes helps. In Stata, there's an option called search that tries to search for the best starting value. And otherwise, you could try the modified Poisson, but it is less efficient, so your standard errors are going to increase a little bit. And in SAS, all you do is create a unique identifier. You can do that with ID equals _ n_. And then you run your GenMod procedure with the Poisson distribution and either link that you want. And this repeated is basically running a generalized estimated equation with robust standard errors. And for Stata, you just use the VCE robust option there. So now for Logistic, which I mentioned before, probably is the optimal way to do these, but there's nothing wrong with the other options either, generally, unless you are getting impossible estimates, which I never have actually. But Logistic always fits. You don't have any convergence problems. It is very popular in our field. It's how we were all kind of trained. The disadvantages is that when you convert to probabilities, the probabilities aren't linear, so you're not going to get the same probability across the spectrum in the population. And you have to choose between these two formulations that I'm going to talk about. So how you obtain the predicted probability is the inverse logit. And so that's taking your odds over 1 plus the odds. And so you can see how this varies depending on what you set your x's at in your model. So this is an example. I'm starting here with Stata now, where we could try to calculate that predicted probability from this logistic model. And we would start with the intercept here to get the odds over 1 plus the odds, and you add in the coefficients. So 0.3065 is the extra log odds of smoking. And then you can add in whatever covariates. So here for age, we put in 25 for age and age squared. And we just use the reference for white women, so we could just keep it easy. And then that is a probability of 10.9%. But that is, again, for this specific covariate pattern. And you could evaluate all of these, the risk difference and relative risk, holding all covariates at their means, and that's called the marginal effect at the mean. But it actually doesn't make sense sometimes. So is there a woman in your data set that is 31% white, 20% black, 41% Hispanic, or even exactly the mean age? And so it is sometimes more popular to take the average of each individual risk difference or risk ratio. So you set everyone, sorry, this is an older slide, to their probability if they smoked and then if they didn't smoked. Marital status was a previous example. And then that's the average marginal effect. And that tends to be more commonly used, I think, among epidemiologists. And there's generally a small difference in large samples. So Stata makes this really easy. Another benefit of Stata here, you just run your logistic model, and there's a margins procedure, and then you put in what change you want to see. So the change in Y over the change in X. So going from 0 to 1 in smoking. And that translates to a 3% increase in the probability of preterm birth. So that's the average individual adjusted risk difference. But you could do the alternative, the marginal effect at the mean. And so here you can see what it's holding the population to, a mean age of 27.5 and all of those race proportions. So the difference is 0.002. It's not really too far off. But I think it does make more sense to really look at the whole population and use that average marginal effect.
I'm not really getting it. Can you go back to that last slide?
Sure.
What's the difference between the average individual adjusted versus the adjusted for the average woman?
So the first one, the average marginal effect, is using everyone in your data set and setting them to smoking and looking at their probability versus their probability without smoking. Whereas the average or the marginal effect at the mean is only calculating one probability at the average of all your covariates. And so that's why it can be a little bit harder to interpret that marginal effect at the mean, because no woman is exactly these characteristics generally. Any other questions? So this margins command in Stata also works on subpopulations, so you can look at additive interactions here. So here we're doing, the first one is again the average marginal effect, and you just do over race, and it will produce the effects by race group. And you can still see this additive interaction where the effect is a little bit larger for Black women. There are no labels, but it's non-Hispanic, white, Black, Hispanic, and other. And then the average, the marginal effect at the mean, which is sometimes called a conditional marginal effect. Again, with large samples, they don't vary that much. So you're not going to get usually any difference in inference. So we can test then what the difference in differences is, which is the interaction effect here. And so you do this post command after margins. So it will calculate the top two estimates are among white women. So when they don't smoke and then when they smoke. And then the bottom two are when non-Hispanic Black women, when they don't smoke and they smoke. So that difference, the effect of smoking, the difference between Black and white women here in this logistic model then is 0.01255. So I think that was a little bit larger than we saw before in the binomial model. And this is different than a model where you actually incorporated an interaction between race and smoking, because that is incorporating a multiplicative interaction. And because we saw that there was slightly a negative multiplicative interaction, your additive interaction is lower here when you have that in the model. It's 0.0086. So it's really two different models. If you're assessing additive, you don't really want that actual interaction in your model, because this is a multiplicative model that we're trying to back convert to probabilities and look at risk differences. And then the rate ratio, after margins, you can do a nonlinear combination, NLCOM, and get 1.31, which is very similar to what we got in the generalized linear models. And there's actually a new command in Stata. It's just an added macro, I guess, and it's called adjusted relative risk, and it computes for a single factor automatically the rate ratio and rate difference here. So that's quite a bit easier, and there's a reference for that. So in SAS, there really isn't as much flexibility. I did find that a macro came out, and Kristen and I were testing it. It will only compute the average marginal effect. And again, that's probably better anyway, because it's looking at the full population in your data set. You can only run one variable of interest at a time and then rerun the macro, and you really can't assess additive interaction with it. But if you're not interested in interaction, just the main effects, it's perfectly fine. And it does handle survey and non-survey data. And just from what I had in previous slides, you do have to add an ID number to your data set, and I showed you how to do that before. And then you enter these inputs, your key predictor of interest and the contrast you want to make between categories, or if it's a continuous variable between certain distances or differences. And enter your model, basically covariates and outcome variable. And I did get this to run, and you get exactly the same thing. The standard errors, I think they compute a little bit differently. But the adjusted risk ratio is 1.31, and the adjusted risk difference is 0.303. You can also do this easily in SAS callable Sudan. Does anyone have access to Sudan? Good. Sudan is really easy with this. The only downside probably is that you really can't assess that additive interaction without including a multiplicative term. So here's the command for Logistic in here. And all you're doing is adding predmark to it. That's going to give you the risk difference and relative risk. And a PRED-F will give you the risk difference. So here you can see those predicted marginal probabilities and what that difference is, and it's the exact same thing as Stata. But we are using it assuming simple random sampling, which does increase the standard error slightly. And comparing the odds ratio to the risk ratio, it really isn't that different, and that's because preterm birth isn't that prevalent. I mean, about 15%, so we see some exaggeration, but not a whole lot. And then here I did show what you can get, the absolute contrast if you did add in a multiplicative interaction here. And it still does show an additive interaction. But again, the interpretation is a little bit different, and we got a little bit different estimates than Stata. So for a complex survey example, I'm going to use the National Survey of Children's Health. There is a newer survey out, but this was already done. It was easy. And so the design here, we have children that are sampled within state-level strata, and we have weights to account for unequal probability of selection, non-response, and population totals. So we're going to look at breastfeeding, a common outcome. So we're going to see big differences between the odds ratio and the relative risk. And I'm going to show you how you can use like multiply imputed data. And we're just doing a simple model with poverty and race here. So the prevalence is 45% of breastfeeding to 6 months here. So we will see those inflated odds ratios. And the SAS linear probability model, OLS, is just proc regress, or you could use survey reg. But again, that's only going to give you the risk differences. And so we see significant effects of both poverty and race here. Highlighted in red. The linear probability model in Stata, you can use MI estimate for the imputation and your subpop statement, and you'll get exactly the same thing. In SAS, the generalized linear model, there is no SAS survey procedure for a GLM that I know of. Kristen, do you know that? Yeah. So you're really stuck with either Sudan or this new macro that was made up, but Kristen and I couldn't get it to work. Or you did? Good. Cool. So with Sudan, Poisson log link may be your only option. That's only relative risks. In Stata, you can do a binomial or a Poisson model. And in Sudan, the logistic, here I have a lot of different PRED-F statements. You have to do them separately to get the risk difference for each category. So those are the risk differences, or those are the actual probabilities, and the risk differences are the PREG-MERD contrasts. So you can calculate that into absolute numbers affected here. The risk difference by the number of children in poverty equals the excess cases here, so I did it for poverty. So if children below poverty had the same probability of being breastfed to 6 months as those at 400% or more, you take that rate difference of 0.18 and multiply it by that 5.1 million, and that's about 1 million more children that would have been breastfed. So again, those absolute numbers are really powerful. And looking at the odds ratio versus the risk ratio, it is basically doubled here for this common outcome. At 400%, it's 2 for an odds ratio versus 1.5. In Stata, this might have changed for the newest, latest edition, but you couldn't previously at least use multiple imputation with these procedures. So you'd have to select one imputation. And again, it's the same kind of commands, the margins that we saw earlier. You just use this VCE unconditional option to help adjust the standard errors for the complex survey. And we're getting like the same estimates here. And this is just a cartoon comparing relative risk to absolute risk. So they did this drug trial and found a 50% reduction in werewolves, I guess. Those who took the drug, there was only one person that turned into a werewolf, and those who didn't, there were 2 people. So in the media, that would blow up like a 50% reduced risk of werewolf conversion. But that actually is only a 1% reduction. So werewolves are very rare. And this is just an example I like to use of kind of responsible media reporting, because those relative risks can really, sound so impressive, but you have to look at that absolute risk difference to know what that actually means. And so this is an example of a study that looked at alcohol use on breast cancer, and they reported both in this study. They have the difference in incidence rates and the relative rate. And so if we kind of look at the last column of cumulative intake, the greater than 30, I think that translated to 2 or more drinks per day compared to none. So that was a 50% increase in breast cancer. But that actually only corresponded to a 1.3% increase in the incidence, and that's just taking 413 minus 281 divided by, I think this is population of 100,000 or something. And so the author was really responsible here in saying that while the increased risk found in this study is real, it is quite small, and women still need to weigh the increased, the beneficial effects of alcohol with the increase in breast cancer with alcohol. So alcohol has been shown to reduce cardiovascular disease. So any woman's decision would factor into whether her behavior would change based on her family history. So luckily, I don't have a family history, and I'm going to take my chances here on the small risk increase. So does anyone have any kind of lingering questions? I really highly advise using both risk differences and risk ratios.
Just in terms of seeing the numbers, could you point out where you see the 1.3% increase?
So that is, I think this is per 10,000 women or something, 100,000 person years. So that's the incidence rate. So that's 413 minus 281. And you kind of can divide that by 100,000 and multiply by 10, I guess, to get over the 10 years. Does that work? No. Mm-hmm.
Additive interactions, additive effect modification is new to me, so I'm trying to figure out what it really is, what it looks like in a model, what it means practically, and if you had a model with both additive and multiplicative, what does that look like? Can you draw a model for that?
I had an example in here. Uh-huh. She's talking about additive interaction being new to her. And so
What does it look like in a model, if you write out a model?
if you have an additive model, it's the same. You're just putting in an interaction effect. And so those terms would be the actual risk difference compared to the reference group. But if you're doing a logistic model, you aren't incorporating any interactions. You're just converting the probabilities or comparing them in two different groups and testing them for significance and difference. So what you have been doing actually, Carol, in Kitagawa is additive interaction. You've been looking at the difference in gestation-specific mortality between two populations. That's an additive interaction, I think. Mm-hmm. It is. The difference in one group minus the difference in another. And it's the absolute difference. So it's just good to, if you are looking at interactions, to look at them in both scales because they might tell you different things and still increase your risk even if it's not multiplicative. And sometimes vice versa. You can sometimes not have an additive interaction when you have a relative risk less than 1 and have a multiplicative instead.